This presentation covers disaster preparedness and the frail elderly, special considerations for a vulnerable population. Emergency preparedness is a topic that seems to be catching the attention of more and more public health officials and practitioners. Recent natural and man-made disasters, probably most importantly Hurricane Katrina, have highlighted flaws in our emergency response plans. And one particular glaring failure is our ability to respond appropriately to especially vulnerable populations, which includes elderly individuals and those with disabilities. So that's what I'm covering today. Now, this topic is a little bit of a strange one. As you might imagine, no one's doing controlled, deliberate, methodical cohort studies in the wake of a hurricane or an earthquake. So a lot of these recommendations are ones established in the field, on the ground, by first responders and care providers who witnessed what went wrong and what best practices might prevent the same mistakes from happening again. So you won't see as many charts and graphs, as much quantitative data as we're used to seeing when we engage a public health issue, but that's just the nature of the beast. With a few statistics about mortality. 71% of deaths due to Hurricane Katrina among persons aged 60 or over, although people in this age group only make up about 15% of the total population. The proportion for Hurricane Rita, which immediately followed, was about 64%. Now, Baylor College of Medicine and the American Medical Association have published the manner and cause of death for these fatalities, and they were seldom due to trauma, but were overwhelmingly caused by chronic conditions that were likely exacerbated due to lack of medications, lack of access to routine care, and exposure to the elements. So we're talking about things like atherosclerotic heart disease, hypertensive heart disease, complications from diabetes, renal failure, end-stage cancers, congestive heart failure, acute myocardial infarction, and in the case of Hurricane Rita, there were lots of deaths from hyperthermia. So the qualitative and the quantitative data suggest that the elderly seem to be especially susceptible to harm in the aftermath of a disaster. Now, to make sure we're not overgeneralizing, I do want to make a distinction. The population we're talking about here is not just anyone over 60 or anyone over 65. The term that keeps showing up in the literature is frail elderly, and I want to describe that population using a definition set by Fernandez and colleagues, and you'll see a full bibliography at the end of this presentation so you can find that source. Here, the frail elder is defined as someone 65 or older with physical, cognitive, social, psychological, and/or economic circumstances that will likely limit their ability to perform or have performed for them one or more activities of daily living or instrumental activities of daily living during and after a disaster. Okay, so what kinds of circumstances are we talking about exactly? Let's break them out and make them a little easier to talk about. We're looking at chronic medical conditions, normal physiological changes associated with the aging process, cognitive and psychological factors, and socioeconomic factors. So the chronic conditions that are most important within this context are going to be those that limit mobility or strength or resilience, and those that require ongoing medication regimens and/or medical treatment. So here's a list of the big ones with the proportion of Americans over 65 who have been diagnosed with these conditions. This is from the Administration on Aging's 2012 report, in case you're wondering. So these are pretty recent statistics. Conditions have a tendency to be exacerbated by the discontinuation of routine medication and medical care, by lack of food, including a lack of specialized food such as low sodium diets for people with hypertension, and again that's about 3/4 of the senior population, a lack of sufficient potable water, exposure to extreme temperatures, stress, and injury. And it just so happens that a lot of that stuff happens in a disaster situation. It's pretty common. Now, these chronic conditions may also require the use of medications or medical equipment that are not usable during extended power outages or that are not available when roads are impassable. So imagine needing insulin when you have no refrigeration and no way to get out of your house, and you understand why someone with this condition would really be at a disadvantage in a disaster situation. Now, absent serious medical conditions, we also have some normal aging processes that affect a larger proportion of the senior population. This may mean that because there are more medications, they have a higher likelihood of drug interactions with prophylactic antibiotics, should they have to be administered. Infections also tend to present atypically among older individuals due to normal physiological changes associated with aging. That includes a change in pulse, respiration rates, body temperatures, and so a lot of these infections may go undetected and untreated. Seniors tend to also be more vulnerable to dehydration and electrolyte imbalances, and also more susceptible to hyperthermia and hypothermia since they often have more trouble regulating their body temperatures. Other issues include impaired balance, decreased motor strength, and sensory deficits, including defects in sight, hearing, even sense of smell and taste, which make it hard to know whether or not your food is spoiled. But some of these other decreases in balance and strength and sight and hearing make it harder to follow evacuation and other safety instructions, especially when it's dark or you're in a noisy environment or when routes of egress from your homes are blocked by felled limbs or other structures or floodwaters. Another disadvantage faced by seniors would include cognitive and psychological factors. It's been estimated that 1 in 6 persons over 65 has some form of dementia, which makes it harder to comprehend evacuation instructions. Seniors may not know their full medical history or medication administration instructions, which makes it hard for care providers to provide the appropriate medical care. They may also not know how to contact relatives, and it's possible that seniors are more susceptible to psychological trauma evoked by a disaster. I have a question mark by this one because the body of literature on this subject is contradictory. Some people or some researchers have argued that because seniors have been through more troubling experiences and have developed more problem-solving skills, they're actually more psychologically resilient. And then some have argued that depression is more prevalent among the senior population, so they may be more vulnerable to the psychological fallout of the trauma. So we're just going to put a pin in that little point for right now. Seniors may also have socioeconomic factors that work against them. They might be more socially isolated than their younger counterparts, and they may also lack the social and economic resources to get back on their feet in the long-term aftermath of a disaster. This means they may have smaller savings accounts, they may not have insurance or appropriate insurance, they may have a hard time obtaining credit to rebuild their homes due to the fact that they're not employed. So how important is this as a public health issue? As of 2011, 28% of adults aged 65 or older who were living in the community reported having difficulty performing at least one activity of daily living, which includes basic tasks like eating, bathing, dressing, or using the toilet. 40% reported difficulty performing at least one instrumental activity of daily living, which includes managing medications, preparing meals, using transportation, housekeeping, some of those higher level functions. So that's a pretty significant proportion of the population. And we also need to look at the growth of the elderly population in the United States. As of 2010, the 65 and older population was right around 40 million. By 2030, we're looking at over 70 million, and by 2050, almost 90 million. So that's 36 million people who need assistance with instrumental activities of daily living, and over 28 million who need help with activities of daily living. So that's a pretty big population that we're talking about being potentially exposed to a catastrophic disaster. Let's talk about appropriate solutions. The recommendations that I found in the literature basically fall under one of three main umbrellas. We can look at preparation that can be done on the individual and household level, preparation that can be done on the government or organizational level, and preparation done at the health agency level. By health agencies, I'm talking about nursing homes, hospitals, long-term care facilities, assisted living facilities. And since as of 2011, 3.6% of the senior population lived in a long-term care type of facility and the rest lived out in the community, I'm going to focus more on the first two, on things that people can do within their households and things that government or organizations can do to assist seniors in disaster situations. Now, several authors caution against reinventing the wheel and instead advocate for partnerships and cross-training among organizations that respond to disasters. So that would be FEMA, the Red Cross, local emergency response systems, and those that serve elderly clients on a routine basis. That would include things like home health, nursing, social work agencies, Meals on Wheels, sometimes church organizations that minister to older folks. So if there's communication and collaboration between these different types of agencies and organizations, that's better than developing a whole new agency or service from the ground up. They also recommend an interdisciplinary workforce that's trained in both emergency response and specifically in geriatric care or geriatric medicine. A lot of authors have also recommended the inclusion of elderly individuals themselves in both the planning and response phases. The argument is, empowerment of the elderly and actually including them in keeping track of what special considerations we might need to make. And also, elderly individuals tend to be more involved in volunteer work and community outreach. And some of the more able-bodied older citizens may be able to help in the midst of a disaster or the immediate aftermath thereof. A recommendation has also been made that shelters, when they're planned ahead, they need to have accessible bathrooms and eating facilities and entrances and so on. Other recommendations include partnerships with media representatives to ensure warnings and instructions are communicated through multiple modes. This is because, a lot of seniors have sensory deficits. Even if they don't hear well, they may see well and be able to see warnings on the scrolling tickers that go across the bottom of a TV screen. If they don't see well, they may be able to hear well in a radio announcement. So we want a lot of redundancy through a lot of different media modalities to reach as many people as possible. Another recommendation has been pre-identification and registration of vulnerable seniors to help them get back into contact with their families, with their PCPs and other healthcare providers and other caretakers that may be able to assist them. Another recommendation has been a hotline for seniors and others who need assistance in the immediate wake of a disaster. And also the establishment of transportation networks to ferry seniors to shelters and possibly to deliver medical supplies or food or transport caregivers to those seniors who find themselves sheltering in place and need some backup supplies. Wait, there's more. Other recommendations are planning for mental health services, which tend to be not as readily accepted by seniors. Mental health services should be delivered by natural community helpers, which would naturally involve some training and mobilization ahead of time. And mental health services tend to be best accepted when they're presented first in the form of practical assistance with the everyday material aspects of recovery, such as finding new housing, reconnecting with medical care providers, social services, and the distribution of actual material and financial aid. There are also some recommendations for assisting individuals and households prepare themselves for a disaster. Self-efficacy is the most important concept here. There's a lot in the literature about empowering seniors and their families and their households to get ready for a disaster situation. Probably for two reasons, because people tend to embrace an idea more when they feel ownership over it, and also because every senior is individual. This is a very heterogeneous population. So each senior needs to be able to identify his or her own needs. Other recommendations would be the preparation of audience-specific educational materials to help seniors and their families assemble a general disaster preparedness kit with some supplemental items related to their own chronic conditions, mobility limitations, sensory limitations, or other special needs. So this would include things like making sure these materials are, in some cases, they may need to be in large print. They may need to be delivered in, audio format. But getting these materials into an audience-appropriate format is the recommendation. And then we would need to distribute these educational materials through audience-appropriate channels such as senior centers, churches, home health nurses, non-medical services for seniors, such as meal delivery, and maybe neighborhood associations or neighborhood watch associations, any kind of community organization that might include our audience that we're trying to reach out to. So for a suggested intervention, we're going to define our target populations. First, we have a primary audience, which would be those that meet the definition of frail elderly that we've already established. And those are adults over 65 with physical, cognitive, social, psychological, and/or economic disadvantages which make them more susceptible to harm during or after a disaster. Another part of our primary audience would be the healthcare and geriatric service providers that serve this population. Our secondary audience, of course, would be family members, other caretakers, and community members who can participate in this preparation and can also participate in the subsequent response in the event of a disaster. So here's our suggested intervention. We've got 3 phases here. First is mobilizing partnerships, the second is creating a plan, and the third is community outreach and education. Mobilizing our partnerships includes, as we've mentioned before, we will want to gather together a coalition of agencies that provide emergency and disaster relief and those that provide services to seniors on a routine basis for the purposes of communication, for cross-training, and for having multiple perspectives to assist with the planning process. And obviously we also want to include representatives from the senior population, representatives from media outlets to develop and carry out the communication plan that we've discussed, social workers to provide assistance with locating permanent housing, assisting with insurance and benefit claims, and other social needs. And we also need gerontologists and other health professionals specializing in the care of older adults. The second phase is creating a plan. We plan ahead for emergency shelter locations. As mentioned before, facilities should be accessible to those with functional limitations, but that don't have special medical needs that require placement in specialized shelters. This is typically how it's done. Those with any kind of limitations are just kind of shunted off to a specialized shelter. The problem there is it separates elderly individuals from their families who can advocate for them and also provide them the peace of mind that most of us would probably need in a crisis situation such as a hurricane or an earthquake. So rather than doing that, we would make shelters accessible for pretty much everyone who doesn't have a kind of a catastrophic medical condition that needs special medical care. We would also want to coordinate with area pharmacies to plan for the replacement of commonly needed medications such as antihypertensives, anticoagulants, and insulin. One of our researchers has identified those who are on anticoagulants for a history of heart disease or of stroke, those who are on insulin regimens for diabetes, and those who are on antihypertensive medication for high blood pressure are the ones that are particularly in trouble in a disaster situation. We would also need to develop evacuation and transportation plans, develop a registry that will allow older individuals to check in with or find family members after a disaster, and we need to coordinate with the media to issue warnings and instructions in multiple formats. Finally, we would want to develop a pre-disaster and post-disaster triage and assessment system. Now, in the Astrodome, In the immediate wake of Hurricane Katrina, a team of about 8 geriatric specialists developed an ad hoc triage protocol for seniors housed in the shelter. They called it SWIFT, for Seniors Without Families Triage. They assessed each person's functional limitations and abilities and made the appropriate referrals based on their degree of autonomy. So this is what the results of the SWIFT tool come up with. They classify each senior, they quantify their functional limitations on a level from 1 to 3, with 3 being those who need the least assistance with ADLs and IADLs. And here is what the evaluation questionnaire looks like. And this was done by usually a pair that included a geriatric physician or nurse and a geriatric social worker who identified seniors in the Astrodome and assessed them. So these are the kinds of questions that they asked. And then they recommended that it be used before a disaster by providers such as home health nurses, physicians, caregivers, and even seniors themselves to assess ahead of time the types of special assistance they might need. The plan here would be training health professionals and social workers in the use of the SWIFT tool or a similar tool that could be developed, but why do extra work when you don't need to? And this tool could be used probably annually. The recommendation has been made to use it every birthday to keep this assessment up to date. And we need to designate team communication leaders to facilitate the use of this triage tool and referral activities that are recommended in the post-disaster phase. Finally, community education and outreach will be the last phase of the intervention. The American Red Cross has published a guide called Disaster Preparedness for Seniors by Seniors. Again, no sense in reinventing the wheel. This is a comprehensive guide that includes their typical disaster preparedness instructions, plus special considerations for seniors. And it's in large print, so it's even formatted well for its appropriate audience. The recommendations line up more or less with the regular American Red Cross recommendations. It includes making a kit, making a plan, and being informed. And I'm not going to read all the little aspects, but you can see the different parts of each of these recommendations. We'll have 2 delivery methods for this curriculum. The first will be through home health care and senior service providers for those who are getting home health, ambulatory kind of care in their homes. So providers will work with elderly individuals and families and their caretakers. They will administer the SWIFT assessment and help households prepare for disaster and prepare a kit and prepare a plan over a 4-week period. And they will also assist and supervise households as they practice deploying their emergency plan. Now, the second method, for those who don't receive any kind of home health care or special services but still want to prepare, will be delivered through senior centers, churches, and neighborhood association meetings. Content will be delivered in a discussion-oriented seminar format. We'll also train neighborhood preparedness leaders who will continue the outreach to their respective neighborhoods and provide an opportunity to join the community that we've developed in Phase 1. We will evaluate this plan by tracking the number of households reached, tracking the proportion of seniors post-intervention who have disaster kits, the proportion who have disaster plans, the proportion who have signed up with the contact registry, and the proportion who have been assessed using. Now, I've put some recommendations for further reading here. If you're interested in this topic, go check out the American Cross Guide, Disaster Preparedness for Seniors by Seniors. They also have one called Disaster Preparedness for People with Disabilities that is also germane to this topic. And finally, the Baylor College of Medicine and the American Medical Association report have published their recommendations for best practices in the management of elderly disaster victims. This is focused on Hurricane Katrina and Hurricane Rita, but they also have an extensive literature review, and the back of this includes an annotated bibliography. So that's kind of interesting if you want to find an article on a specific aspect of disaster preparedness for elderly folks. And this is my full bibliography. Thank you for your time. I'm also going to include the regular PowerPoint presentation without narration so that you can visit my links and check out more of the bibliography if you're so inclined.